A very good day, class, to everyone. For this session, we're going to discuss the bacterial group of organisms we call Neisseria. At the end of this session, the student is expected to be able to discuss the different characteristics of the genus Neisseria and to differentiate as well the two major organisms belonging to it, Neisseria gonorrhoeae and Neisseria meningitidis. Explain the clinical presentation, epidemiology, diagnosis, and treatment of both gonococcal infection as well as meningococcal infection. The Neisseria organisms are gram-negative diplococci, and they are often found in pairs. And very often, the adjacent sides look flattened. The organisms are aerobic and are oxidase positive and are relatively more difficult to grow. They are classified as fastigious organisms. The two important members are Neisseria gonorrhoeae or gonococcus and Neisseria meningitidis or meningococcus. So this is how they would appear on gram stain as gram-negative organisms. And when you stain clinical specimens, an important clue to their presence would be their intracellular location, as you see on the right picture. There are important virulence factors, the pili or the fimbriae, which the organism can use to attach to mucosal surfaces. They can mutate, for example, and can turn pili expression on and off. The P2 outer membrane protein, adhesin, serves also to attach the organism together with the pili to mucosal surfaces. They also have transferrin and lactoferrin binding proteins, which are iron uptake mechanisms. Their ability to produce an IgA protease is considered to be a virulence property because secretory IgA is important in mucosal surfaces. Because they contain lipooligosaccharide, this may be considered another virulence factor that can result in destruction of tissues as well as generating a cytokine storm in severe cases. Let us first consider Neisseria gonorrhoeae, which causes a common condition called gonorrhea. Gonorrhea is a sexually transmitted disease that may affect both men and women, primarily affecting the genital organs like the cervix, the uterus, and the fallopian tubes in women, and the urethra in both men and women. They can also infect the mouth or throat, as well as the rectal area. The eyes can also become infected when the organism gets inoculated into the eyes, as in ophthalmia neonatorum, which is gotten by the newborn on passage through an infected birth canal. This is a very common infection. The US CDC estimates that there are more than 700,000 persons, for example, in the United States that get new gonorrheal infections every year. And it is spread through direct contact with the penis, the vagina, the mouth, or contact with the anus, and can also be spread from the mother to the baby, as I mentioned, during delivery. The incubation period is usually short, about 2 to 5 days, and usually less than a week. However, there are reported cases which take as long as 30 days for the symptoms to appear. When present, the most common symptom of urethritis is a burning sensation when urinating. often accompanied by a white, yellow, or green discharge from the penis. When you have testicular infection as well, you may, you may have painful or swollen testicles. In women, symptoms are often mild or not present. That is why women may come in late for treatment and may present with serious complications from infection because complications can happen even if symptoms are absent. When present, the symptoms may be nonspecific and may be mistaken for a UTI or cystitis. When urethritis is present, they may have painful burning sensation as well when urinating, increased vaginal discharge, or vaginal bleeding in between periods. Proctitis or rectal infection can occur in both men and women depending on the predisposing sexual practice and may include discharge, anal itching, soreness, bleeding, or painful bowel movements. The organism should not be found in the throat, so the presence of Neisseria gonorrhea in the throat is always pathogenic. However, oftentimes it causes no symptoms. Newborns may get this type of eye infection, gonococcal ophthalmia neonatorum, which leads to a lot of purulent discharge and swelling or chemosis of the eyelids. This is prevented by the so-called cridase prophylaxis or silver nitrate, topical silver nitrate applied to the eyes of all newborns at birth. There is also a regimen that utilizes instead of silver nitrate, erythromycin ointment. A similar condition may be caused by a related or by a different organism, which is called Chlamydia trachomatis. So Chlamydia ophthalmia, however, is different from gonococcal ophthalmia. When untreated, gonorrhea can present with complications like pelvic inflammatory disease. It can also lead to epididymitis in men. When it gets to the bloodstream, it may present with sepsis, as well as arthritis, which can be very damaging to the affected joint. When ophthalmia neonatorum is untreated, it can lead to blindness of the neonate. The diagnosis is definitively made by culturing the organism on selected medium like Fair Martin medium, which is actually chocolate agar with vancomycin, colistin, and nystatin. When you use only a gram stain smear of the urethral, cervical, or rectal specimen, and you demonstrate intracellular gram-negative cocci, this would constitute presumptive diagnosis. There are no serologic tests which are available for gonorrhea. Now, the Fair Martin medium can be modified. For example, you can add trimethoprim to vancomycin, colistin, and nystatin. Now, vancomycin is there to inhibit gram-positive bacteria. Colistin can inhibit gram-negative bacteria. Trimethoprim can suppress Proteus. And nystatin can inhibit Candida, for example. And the reason for adding these antimicrobials to the medium would be because these organisms can be found contaminating the urethra. The chocolate color of the chocolate agar is due to the hemoglobin enrichment, which is gotten by heating red blood cells that are added to the medium. Neisseria gonorrhoeae can be differentiated from Neisseria meningitidis by their utilization of sugar. For example, Neisseria gonorrhoeae utilizes glucose, but not maltose and sucrose, whereas Neisseria meningitidis utilizes both glucose and maltose, but not sucrose. It used to be that the treatment of gonorrhea was penicillin, but because of plasmid-mediated resistance, penicillin is no longer the drug of choice. The drug of choice is ceftriaxone, which is a third-generation cephalosporin given as a single dose IM, or oral cefixime, which is a third-generation oral cephalosporin. Now, when treating gonorrhea, it's very important to treat also for non-gonococcal urethritis caused by Chlamydia trachomatis. This is often done because chlamydia diagnosis cannot often be accomplished in many laboratories. So when treating gonorrhea, you treat as well for chlamydia. For disseminated gonococcal infection, you give ceftriaxone every 24 hours till about 48 hours after clinical improvement, followed by a step down to oral cefixime twice daily. Now, if you diagnose gonorrhea in a patient, it's very important as well to rule out for other sexually transmitted infections that include syphilis, for example, as well as human immunodeficiency virus, and to treat the sexual partner as well. We come now to meningococcus or Neisseria meningitidis. These organisms possess a capsule. They also have an outer membrane protein with lipo-oligosaccharide as well as pili. They grow best on chocolate agar and are divided into serogroups based on the type and arrangement of sugar or polysaccharide in the capsule. Within serogroups, there are also serotypes and subtypes. And the two most dangerous forms of the disease are meningococcemia and meningitis. Meningococcemia is sepsis, and meningitis is infection of the meninges of the brain. Based on the capsule, there are 13 serogroups, of which 6 cause the most important disease worldwide. Serogroup A, B, and C are the most common causes of invasive disease worldwide, followed by W and now X as well. Serogroup A is the most common cause of epidemics in poor countries. Serogroup B is the most common cause of sporadic disease. Serogroup C can also cause epidemics. Serogroup Y may cause a primary pneumonia. There has been a recent increase with W. This was formerly called W135, as well as X. The other serogroups are listed down below. The disease may not be as common as other diseases. For example, in the US and Europe, you only have about 0.9 to 3 cases per 100,000. And in developing countries, however, you can have as high as 10 to 25 per 100,000. And there are certain areas of the world where the incidence can be very high, as in sub-Saharan Africa, called the meningitis belt, as shown here in the map, colored yellow, where rates may be as high as 1,000 per 100,000. Invasive meningococcal disease can also lead to outbreaks. For example, there were documented outbreaks like in the year 2000, which was associated with the annual pilgrimage to Mecca. In general, A, B, and C, as I mentioned, account for the majority of diseases, with serogroup Y, W, and X accounting for the rest. There is no gender predilection, and as far as timing of disease is concerned, in Africa, and which has hot weather, it peaks during the dry season and wanes in the rainy season, but in the US, it's more common in the winter months. There are differences geographically as to the prevalent serogroups, as you can see in the map. When you look at temporal variation, you will also find temporal variations. For example, group A used to be very common, as shown in this map, in Africa, but as a result of the use of vaccine, they now have W as well as C being the most common. In Europe, as in the UK, for example, C tended to be more common, but because of the use of a vaccine, it has now decreased, only to be replaced by other serogroups. It can occur as epidemics. For example, there was an outbreak in the Baguio City area in 2004 to 2005 with more than 90 reported cases. It's important to remember that invasive meningococcal disease can have a high case fatality, and in that particular epidemic, one-third of affected patients died. There is the phenomenon of nasopharyngeal carriage for meningococcus. The human nasopharynx is the only natural reservoir of the organism. Carriage rates vary depending on age, and carriage rates are very much lower in infants and children compared to adolescents as well as adults. Carriage is not a lifelong thing, but it can last for months. In household contacts of index cases, about 10 to 35% had a mean duration of carriage of about 9 months. Carriage may lead to immunity, although it may lead to disease as well. What factors are responsible for converting carriage to invasive disease? Well, we cannot provide a definite answer to this, but it may be lack of protective antibodies, and the antibodies we're talking about here are antibodies against the capsule of the organism. There are other risk factors like various forms of crowding, a young age, because the immune system is just developing. Now, we mentioned crowding. So military recruits, students living in college dorms, for example, are at higher risk of getting invasive disease. Lower socioeconomic class, mainly because of crowded living conditions. The presence of a concurrent upper respiratory viral illness, and various forms of immunodeficiency. In particular, the most prominent are complement deficiency. Patients with terminal complement complex deficiency can have repeated episodes of meningococcal meningitis. The lack of functioning spleen can lead to a higher risk of getting meningococcal invasion, principally because the spleen is an important organ that is useful against encapsulated organisms like meningococcus, pneumococcus, as well as Haemophilus influenzae type B. Now, when severe, there is a high case fatality, as I mentioned, and it can affect principally any organ. In autopsied cases, myocarditis is present in the large majority. A lot of patients may die from septic shock induced by a cytokine storm. And the key virulence factor here is the lipo-oligosaccharide present in the organism. In patients dying from meningococcal disease, adrenal hemorrhage may be seen in about 50%, and the combination of adrenal hemorrhage and septic shock is what you call Waterhouse-Friderichsen syndrome. You can have various types of clinical presentation, from asymptomatic transient bacteremia to the two most important forms of invasive disease, sepsis or meningococcemia, and meningitis. Meningitis may be present with or without meningococcemia. Pneumonia may be produced commonly by serogroup Y. Chronic meningococcemia is rare, but it can infect other organs. You may have pharyngitis, conjunctivitis, arthritis, and as I mentioned, myocarditis as well as presentations. The disease occurs quite fast in tempo. The incubation period is about less than 4 days, but can range from 1 to 10 days. The early symptoms, however, are non-specific. If you look at the list, these early symptoms like coryza, pharyngitis, tonsillitis, and laryngitis may be seen in a lot of other viral infections, together with the other symptoms like fever, headache. There are symptoms that may point to meningeal involvement, like stiff neck, seizures, and lethargy. However, there may be prominent skin manifestations like petechia and purpura. Here you see an affected patient with petechia. It's estimated that about 60% of meningococcemia may present with petechia, and about only 10% may present with a macular rash, which simulates a viral exanthem, although meningococcemia is, of course, of bacterial etiology. Purpura are distinct from petechia because purpura are bigger. And here you see purpuric lesions in two affected patients. You see purpuric lesions on the left side together with petechia on the arm, and on the right side, more extensive purpura, indicating more severe disease. The occurrence of a rash may be rapid, and the patient may die in 24 to 48 hours. The meningococcemia rash generally do not blanch on pressure, but can be very severe, accompanied by shock. When generalized and accompanied by shock, the condition is called purpura fulminans and often leads to death. The diagnosis is confirmed by isolating the organism from a sterile site in a person with clinically compatible illness, but you can make a presumptive diagnosis by doing a gram stain from a sterile fluid, or you can even do petechial scrapings and get the organism on gram stain. A probable diagnosis is made when you have a positive antigen test, such as latex particle agglutination of the CSF, in the absence of a positive culture, or when you have a case of purpura fulminans in the absence of a positive blood culture. It's important to give early treatment, even when you're dealing with just a presumptive or probable case, because early treatment is an important way to influence the outcome of the patient. Penicillin G is a drug of choice, and unlike gonococcus, meningococcus have very, very rarely become resistant to penicillin. So you can use penicillin G for treatment. The duration of treatment is 5 to 7 days, with 7 days being used to treat meningococcal meningitis. When treating meningitis, for example, empirically, before identifying the organism, you may want to give a broader spectrum antibiotic like cefotaxime or ceftriaxone, principally for the reason that you want to cover as well for Haemophilus influenzae type B as well as Streptococcus pneumoniae. For those with allergy to penicillin, chloramphenicol may be used. It's important to isolate these patients because the disease is transmitted through droplet transmission. Droplets are big particles, so if you're within 3 to 6 feet of an index case, you may get infected. And droplet precautions are put in place till 24 hours after initiation of effective antibiotic therapy. Now, droplet precautions involve putting the patient in a private room, or if not, you may cohort similar cases. And the use of a mask if you're going to come within 3 to 6 feet of the patient. The use of a gown or gloves if you're going to come into contact with secretions from a patient is also advised. For those with exposure to an index case, careful observation is very important. Chemoprophylaxis using antibiotics may be given as well. The use of meningococcal vaccine, for example, in high-risk patients is also advised, as well as for outbreak situations. Meningococcinia and meningococcal meningitis are reportable diseases, and counseling and public education may do much to reduce disease. Here are the chemoprophylactic agents that are recommended. For children, it's rifampicin in the doses that are specified in this table. You have to give it twice a day for 2 consecutive days. Ceftriaxone, for example, may be given, however, to pregnant women for whom rifampicin or rifampin use is not advised, but it has to be given IM since there is no oral preparation. It is given as a single dose, with the dose dependent on the age. For adults, a single dose of 500 milligrams of ciprofloxacin may be used for chemoprophylaxis. But who should receive chemoprophylaxis? Only high-risk contacts, meaning household contacts, especially children, childcare or nursery school contacts, during the 7 days before the onset of illness in the index case. Direct exposure to an index patient secretions through kissing, sharing toothbrush, utensils during the 7 days before the onset of illness. Healthcare personnel who do mouth-to-mouth resuscitation. And if you have unprotected contact during intubation, you did not wear a mask, for example, during the 7 days before the onset of illness in the index case. If you frequently slept or ate in the same dwelling as the index patient during 7 days before the onset of illness. Now, prophylaxis should also be given to the index patient because penicillin does not eradicate the organism from the nasopharynx. However, if you gave ceftriaxone to the index patient or to the patient itself, then you do not need to give additional prophylaxis. Now, casual contacts, indirect contacts, and healthcare professionals without direct exposure to the patient's oral secretions do not need to receive prophylaxis except when recommended during outbreak situations by local health authorities. The 2 available types of vaccines for meningococcus are polysaccharide capsule-based vaccines. The non-conjugate polysaccharide capsule-based vaccine contains, for example, the capsules of A, C, Y, and W. But when you say conjugate polysaccharide capsule-based vaccine, you mean that each of the capsular polysaccharides is conjugated to a protein to make it more immunogenic. That protein, for example, may be tetanus toxoid, or it may be another type of protein like diphtheria toxoid. The conjugate vaccines can be used even in younger patients because they are immunogenic even at a younger age compared to non-conjugate vaccines. They also give a booster response compared to non-conjugate vaccines, which do not elicit the help of T helper cells when given to a patient. Serogroup B capsule is relatively non-immunogenic because it has similarity to nerve tissue in humans. Therefore, you cannot use or prepare a group B polysaccharide-based vaccine. There are two recent vaccines which are protein-based and are mainly used for serogroup B, but they are not available in the Philippine setting. In the US and some other countries, these serogroup B vaccines have been used in certain outbreaks, for example, in colleges, in college dorms. So, as a summary, we have discussed the general characteristics of Neisseria organisms, and we have discussed in particular Neisseria gonorrhoeae or gonococcus and Neisseria meningitidis or meningococcus. We have discussed the epidemiology, the clinical presentation, the way they are transmitted, the management, as well as the prevention of these diseases.
Thank you very much.